Go live. Let's try it. Well, we are live. Thanks for joining us. This is HEILive number 2. And tonight's topic is hearing loss and cochlear implants. And we have Dr. Jordan Rock with us tonight. Thankful for Jordan being with us and taking time out of his schedule. And just before we begin, just wanted to just read our informational message for those who are joining us. HEILive Ear Institute may from time to time present informational sessions on medical topics via social media such as Facebook, YouTube, and other social media outlets. These informational sessions are for informational purposes only and should not be considered medical advice. These informational sessions are not intended to be a substitute for individualized medical advice, diagnosis, or treatment by a physician who is aware of your medical history and has had an opportunity to examine you. Do not rely on any informational sessions presented via HEILive Ear Institute social media in place of seeking professional medical advice. Well, we're happy to be talking on this topic tonight, and we have a number of things we want to run over with Jordan tonight. And I think what we'll start with is just the concept of what a cochlear implant is and how it might be different from a hearing aid or something else that someone might be familiar with. Jordan, can you just briefly tell us a little bit about what cochlear implants are and why we have them?
Yeah, sure. So cochlear implants are a solution for people with what we consider a severe to profound hearing loss. That differs from traditional hearing aids in that hearing aids are usually used for people with anywhere from a mild to a severe hearing loss. Once they progress beyond that, hearing aids can't really help much. Now, the reason for that is that a traditional hearing aid will take an acoustic sound and make it a louder acoustic sound. But at a certain point, we can turn the volume up all the way, and that's, for some people, it's not going to help that much. So we then turn to a cochlear implant, which will take an acoustic sound and turn it into an electric sound. Now, what I mean by that is that the electric sound will stimulate the hearing nerve directly and bypass the damaged part of the hearing system, which is typically the inner ear. So kind of that make or break point that we consider is when if we're turning the volume up with a hearing aid and it's still not helping people hear or understand speech, conversational speech any better, that's when we turn to a cochlear implant as an option.
Great. I have just a small model here. I'll try to put it up to show just what the size of the internal device is. This is the internal component, and other companies are similar in terms of the size and the shape. And there's a coil on it, which has where the magnet will be attached through the skin, and there's a receiver stimulator, which is where the electronics are located, and then there's a cable with electrode contacts on it that are put into the cochlea. And then there's also an external part that is programmed by the audiologist and can be adjusted and upgraded on the outside. So it's really kind of a two-part system in terms of its structure. And so just wanted to give a little bit of background on that. So I think we have feedback that we are online and we have people watching. So the way this works is we have a number of topics we want to go over, but if anyone wants to ask a question, feel free to put it in the comment box, and that'll show up for us, and we'll try to get to those. We anticipate we'll probably have 30 to 45 minutes tonight to review these topics. So please chime in if you have a question about cochlear implants or severe hearing loss and so forth. So one question I have for you, Jordan, is what's changed in the last 10 years in terms of candidacy for implants? What has changed in this field? Are we seeing people with perhaps less hearing loss than before that are candidates for cochlear implants now? And do you still see, I mean, going along with that, do you still see, why don't you answer that first, and then I've got kind of a follow-up to that.
Yeah, so the Candidacy has changed quite a bit from back in the day when cochlear implants were first being implanted. These days we can go with a traditional implantation where we use that electrode array that you showed earlier to replace all of the hearing within the cochlea. That's the sensory organ for hearing. But now there's also a type of procedure we can do where we preserve some of that hearing, that acoustic hearing I mentioned earlier, and we combine it with the electric hearing, which allows your brain it gives your brain a little bit more context when you're learning how to use this device. With that approach, we preserve usually the low frequencies. Those are the bass tones, kind of where we get the energy from speech, as opposed to the high pitches, which give us the clarity of speech. For most people, as you lose hearing loss, whether it's from old age, from any kind of infection, whether it's a sudden loss, most people will typically lose the high frequencies first, and then the low frequencies will progress later on. But for those who have a fairly stable hearing loss that's only in the high frequencies, we can do what's called a partial insertion of the implant and preserve those low pitches. So historically, that hasn't been an available option for most people, but as of the last 10, 15 years, we're seeing it more and more. And those patients tend to do quite well.
What kind of things would someone with a hearing aid, as they start to lose more and more mid and high frequency, but have preserved low frequency hearing, what kind of things are they going to notice as they go throughout their life? What kinds of situations are they going to have trouble with, and what kinds of speech are they going to have trouble with as that happens?
That's a very, very good question, and I think it's going to be different for every single case, every patient, every ear. I can tell you that most of the common complaints we get from patients who are suitable implant candidates, they're having a lot of difficulty in background noise. They're having trouble speaking over the phone. They're having problems hearing other people when family and friends are trying to talk to them, maybe from another room. Now, a lot of these issues are still pretty common for people who are using hearing aids. So it's a little tough to figure out whether someone should stay the course with hearing aids or maybe try something new with a cochlear implant. And that's why at many clinics that do cochlear implant surgeries, they will have patients come for a session or two where they can do some testing and some evaluation to determine, well, are you really at that point? Should we proceed with the surgery? And I think a big part of that is not just what the test results say. I mean, we can put you in a booth and see whether with hearing aids you will be able to understand speech okay, or if with hearing aids you can't really understand much. But beyond that, we need to make sure that someone who wants this surgery is willing to go through the rehabilitation process as well. Getting a cochlear implant is not a perfect fix. It's difficult to know based on the measurements and the tests whether a patient will truly succeed with it. We have to make sure that those people are ready to commit, to be motivated, and to have patience with it is very important.
Yeah, it's when I talk to patients about cochlear implants, a lot of them are hesitant, and a lot of the hesitancy and concern comes with the surgical part. And I joke with patients a little bit, saying that the surgery is the easy part, and the learning and programming and the brain adaptation is the difficult part. And people kind of look at me a little funny when I say that, but really, I mean, the surgical implantation is really, it's outpatient surgery. It's typically very well tolerated, very little pain, and then the real work begins. I'll give you just a brief kind of anecdote. I had a patient an older patient, and this is another thing potentially we can talk about is effects of age on cochlear implant candidacy and what issues come up. But I had a patient who was in his early 70s, and he had been implanted for about 5 to 6 months, and he was somewhat frustrated with the benefits he was receiving from the implant. And then about after another month, this is about 6.5, 7 months after the surgery, the brain really clicked for him, and he came in and reported at that point that, you know, he was happy he had it done. It was providing benefit. And I think he was probably, you know, in terms of the population group, he was probably a little bit on the slow end in terms of getting that benefit. But I think it's important. The expectations the patients have are very important, and counseling them on the fact that this is really a procedure that's going to take the brain some time to learn and gain. So can you comment a little bit about the quality of the information the brain is receiving from the implant? How is it? What do we know about the quality of the information received through a cochlear implant?
That's another pretty difficult one, and that's going to vary on a lot of different factors. The duration of hearing loss, the reason for the hearing loss, a whole lot of different factors come into play with this. Most commonly, people say it's mechanical or robotic sounding, but we've gotten everything from, it sounds like Mickey Mouse, it sounds like Darth Vader. It really is different for every patient, every ear, every surgery, et cetera, et cetera. Excuse me. But one story I like to tell a lot of people, and this came from one of our older audiologists a few years back, Dr. Jane Gay. She would tell patients to imagine you are blind, and then one day you go to the beach, and all of a sudden you can see people on the beach, you can see the towels, you can see the water, the sky, the clouds, but for some reason the water's black. And you know that the water is blue. You know in your head that, and you're expecting the water to be blue, but for some reason it's black. And with a cochlear implant, we can kind of make the metaphor still stands a little bit. The water might always be black for someone with a cochlear implant. In your brain, you know that it's supposed to be blue, and you really want your brain to just click like that and to really hear it the way that you once did. But for some people, it never gets to that point. And it's important to remember that, with that analogy, you're seeing the beach, you're seeing everything that you were missing out on, but it might just be a little bit off. It might never correct itself. I always say that the sound is never going to be normal, but at some point it becomes ordinary. So at some point you'll get used to that water being black, but that part takes a lot of motivation and patience. And as long as you're willing to put in that work and to come back and to keep at it, then over time it's going to really make a big improvement in your life if you need it.
Yeah, and the counterpoint to the story that I told about an older patient who perhaps takes longer to adapt and have brain compensation and learning, we have other patients also in their 60s, 70s, and 80s, which is our biggest growth group really for adult implant recipients. Some of those patients really even immediately get benefit, but like you said, the quality of the sound, the speech information is not exactly what they were used to, but it does become sort of a new normal for them. But it is amazing to me how quickly many people adapt. One other story is I have a patient in his early 80s who was implanted, and he hadn't had a conversation with his daughter in 7 months. And he immediately, after the implant was activated, he had a conversation with his daughter. Some people were able to talk on the phone pretty quickly. And so it's incredible to me that a device like this can provide an 80-year-old person, 80-year-old patient, with almost immediate benefit to have restoration of communication. It's incredible to me that this occurs, and I think it shows us that the inner ear is only part of hearing and the brain is the rest. We know we talk about the brain ear, but there really is a huge component to cognition, working memory, and this in terms of how the brain takes that information and processes it. Can you comment a little bit on what you've seen in patients who are perhaps older And what do you have to do any particular special things with programming them? Are there, do they benefit from any particular strategies in terms of being able to learn their device? What do you recommend for someone, say, who's over age 65 as opposed to someone who's younger? Do you make any changes based on the age of the patient?
Not really. With age, it's less a question of age as it is a question of how much time have they spent without any hearing on that implanted ear. If a patient comes in and let's say they're 60 years old and they've worn a hearing aid for the last 20 years, ever since they first noticed their hearing loss, that patient will probably do much better with a cochlear implant than someone who, say, they were 60 years old and they had never worn a hearing aid and they needed one 30 years ago. When you don't have stimulation to that ear, when that hearing nerve isn't really receiving anything, it starts to atrophy, just like a muscle. It needs that sound. It's exercise for that side. So when we don't get it that regular input, then those parts of the brain kind of start to forget about that side. And when we do that, providing the electric stimulation doesn't really compute with the brain as well as it would for someone who's worn hearing aids consistently. So when people come into my office, that's one of the first things I ask them about is whether or not they've worn hearing aids for the duration of their hearing loss, and if they've had success with it, if they stopped wearing it because there was no benefit. That definitely matters a lot more than their age. I've seen patients who are in their 90s who, as soon as we turn them on, they're doing quite well. And I've also seen some patients who are fairly young that they don't do so well because they never wore their hearing aids. That's not to try to get you all to go out and get hearing aids right now. I know that financially that can be a really difficult thing for a lot of people. A cochlear implant is usually covered by insurance if you qualify, if you meet the criteria to get one. So we have to spend a fair amount of time doing tests to determine your candidacy, and then more follow-up to just make sure you're ready for the jump. Once we do the surgery, we are taking away whatever remaining hearing you have on that side. So we are taking a jump, and there's no real looking back. Once we do that, we want to make sure that you're ready to get in the routines and to go about the follow-up care so that we can work together to help give you the best outcomes.
Great. We talked about duration of deafness that's been fitted with a hearing aid as a marker for someone who might be a good candidate. Are there any questions that you ask in the evaluation process or any markers that correlate with performance other than what you mentioned about whether someone's been using a hearing aid during the duration of their hearing loss? Is there a question that you ask patients that correlates somehow with how they're going to do? In other words, are there key markers that tell you this patient's going to do better than somebody else with their implant?
Really, duration, I think, is one of the bigger ones we look for. So if I go completely deaf out of nowhere on a Monday afternoon and I get my implant on a Tuesday, my hearing nerve is very healthy. It's very strong. We just replace the input from that acoustic to electric. So if that's the case, I'm likely to do pretty well just because that neural system is still very much intact. But if I go deaf in 2017 and I don't do anything about it until 2030, 2050, that's when we're going to start to see that atrophy comes into play, and I'll have a harder time catching up. Now, you mentioned earlier about are there different strategies for stimulation strategies or techniques we can use in the programming? Yes, there are. We usually try to go with whatever the manufacturer recommends for their presets, and if that works, then great. We'll go with that setting, and we'll see if we have to tweak it just a little bit. In some cases, we do have to go astray from those recommendations quite a bit, but in most cases we can find something that's suitable for the patient, that's providing them with clearer speech than any other alternative. That's where my job comes in, is knowing which techniques to use, how to present the sound for you. Your job as a cochlear implant user is to go out into the world and listen to everything to get you back into your daily activities that you've been missing out on. We also recommend, after people are initially activated, that's what we call the point when we turn on the implant. We recommend that they get about 30 minutes of practice a day. This is kind of like learning a new musical instrument, say learning the piano for the first time. You need to get about 30 minutes to an hour of practice a day with that. And no, watching TV doesn't count, sorry. But things like reading out loud to yourself so that you can visually confirm the words you're hearing. Podcasts, different, listening to the radio, anything where you're really focusing in on the speech you're trying to hear so that it will give your brain some focused effort, some time with that. That will definitely help the process. We typically see the biggest improvements in the first 6 months of device use, and then smaller improvements after that. I have had patients who are 5 years out improve pretty significantly on their speech test scores, which we measure afterwards. But a lot of this is contingent on you as a patient wearing your device all day. We talked about that external processor that's worn on the ear, kind of like a hearing aid. You have to wear that all day to get used to it, the same way that I wear my glasses from the moment I wake up till the moment I go to bed. That's a really big thing for many patients. Now, at that initial activation appointment, what I like to do, I make sure first and foremost that the volume of the sound is comfortable. As long as it's comfortable, that enables you to wear the device all day. If it's too loud, then you won't want to wear it for 5 seconds, let alone a few hours. So at the first appointment, we're really focused on the comfort of the device. And then later on, we work on improving the clarity, tweaking the bass and the treble settings to try to make it sound a little bit better for you.
Great. I mean, this is a highly specialized area of audiology, and you're expert in what you do. We hear a lot about the new technology coming out with external processors from the different manufacturers. What are the new technological advances in the external processor arena? When the companies come out with a new external and everyone wants to upgrade, what are the bells and whistles that are coming out that everyone wants to upgrade for? Is there anything that's actually changing the device function, or is it just simply accessories and things like that? Or a combination?
Yeah, that's a good question. Yeah, it's strange. A lot of the time, the choice that the patient makes as to which company's device they want, a lot of times it comes down to accessories, and that's not the way you want it to be. But to back up a bit, between the three manufacturers, that's Advanced Bionics, Cochlear Americas, and Med-El, the outcomes are pretty consistent for all three. There's no one company that's going to provide you with better hearing compared to the others. It really comes down to a choice of what features, what accessories, what components are going to be best for you with your life and the work you do, the activities you enjoy, the environments you're in. So we try to work with each patient to determine which is the most suitable option for them. In terms of what big features are available now that people are really excited about, I think my favorite is the automatic processing that's now available for all three manufacturers. What that does is it senses the types of sound in your environment. So if it's a quiet environment and there's a couple people talking, each device will register that, and as soon as you go into a noisy situation, it's going to default to a setting that is suitable for noise. It will reduce the background noise behind you and try to boost the speech of whoever's talking in front of you. So that's available with all three companies, and we're really starting to see that patients are doing well in noise in ways that they couldn't before with older technology. Just going back a bit, I mentioned earlier that speech and noise is one of the biggest complaints for most people with hearing aids and with cochlear implants. But now that we have a lot of these automatic features, I think many people are utilizing them more, and they're doing quite well with them. There's also something to be said about in the past you would have a program for quiet, one for noisy places, one for restaurants, music, etc., etc. But now we're giving patients a single program, or maybe two, that can handle all of those situations. So they don't have to fish for a remote control in their pocket. They can just let the device work on its own. For those people who do like having that control, each company does provide a different type of remote or ear level button that you can press to change the volume or program. But hopefully in the future, everything will be totally automated and you won't have to worry about it.
I want to go back to what you were talking about before about low frequency hearing, because that's something that we are able to do now with patients. We're able to do a hearing preservation surgery and save low frequency hearing. And as you mentioned, we're able to use the electric hearing, meaning the implant, and the acoustic hearing, meaning the hearing aid portion together. What benefits are you seeing in patients that have both of those components over just the implant alone? How is that low frequency information helping people?
That's a very good question. It helps a lot for those patients who we can preserve their low frequency hearing. That gives the brain some context with this new electric sound. It's sort of like learning to walk with a prosthetic leg, but you also have a crutch that you can rely on. It gives you a bit of a jump start. Now, between all three companies with the full insertion of the device, when you're relying on those electric cues only, the results are the same. But for those patients who are lucky enough that we can preserve their low frequency hearing, they tend to do quite a bit better than the traditional approach. Unfortunately, not everybody is a candidate for that. Many of the patients, I would say most of the patients that we see for cochlear implants, they do not have significant low frequency residual hearing that we can save. But for those that are lucky enough to be in that position, we almost always go with that approach to try to save whatever we can. When we can incorporate that acoustic information, it tends to make the sound much more natural for people.
That's great. We have a number of people watching, so if you have any questions, please put it in the comments. And if you have a specific question you want answered about implants, this is the time to do it. We've got Dr. Rock here, who's got a lot of experience with this, and so I want to go back also and talk a little bit about whether we do one or two. So when we evaluate patients, obviously these patients, even with their hearing aids on, are doing very poorly with speech understanding. So how do we decide in an adult patient to do one versus two? How often does that come up? How often do you see that come up?
Most of the time here at House Clinic, we're going with a single implant. Oftentimes we have to decide which ear, whether to implant the better hearing ear or the poorer hearing ear. There are a few cases where we have to consider implanting both ears at the same time. The one that stands out to me is that when a patient has meningitis, that will ossify the cochlea, meaning their hearing organ will turn into bone. It essentially becomes a rock. And once that happens, we cannot put a cochlear implant in the cochlea. So in that case, we're dealing with a pretty limited time window. And if we see a patient in that situation, that's when we might consider doing a bilateral or two-sided surgery, because in the future we won't be able to put an implant in their other ear. With most other cases, we can start with one, and then later on, if that first one isn't working too well, or if the patient is really interested in getting the second side done as well, we have the time. We're not dealing with any time restrictions, so to say. That's way different for adults than it is for pediatric patients. With kids, there's an abundance of research that shows that getting them two cochlear implants, if they're needed, is going to be much better for them later on than doing one implant and then waiting a little while. We call that simultaneous surgery versus sequential surgery. Now, here at House Clinic, I don't work with pediatric patients. I'm mostly with adults, but we do have a care center here that works with pediatrics. And for all of you watching who have children who may be candidates for hearing aids or cochlear implants, I would definitely contact us. We can put you in touch with them and get you the information you need. But regarding adults, it's almost always just one implant at a time.
So we had a couple questions show up, and both of these questions have to do with a topic that we can mention a little bit about. One is the questions have to do with a patient who has very, very poor hearing in one ear and one ear that has better hearing. Probably with a hearing aid, the patient is doing fairly well on that side with speech understanding. So currently, FDA, the Food and Drug Administration of the United States, regulates medical devices, and the current approved indications for cochlear implants in the United States for adults are for severe to profound sensory hearing loss with poor word understanding, and this is assessed by a variety of word and sentence tests that the audiologists administer. So in terms of single-sided hearing loss or one-sided hearing loss with one ear that is serviceable or normal, there have been a couple of studies performed in the United States. One was done by us involving patients with single-sided hearing loss. This is not currently an FDA-approved indication, but what the studies are showing, and we're seeing in these patients, is that the benefits of two ears, and this is probably something that Jordan, we can comment on too, is that with two ears, there are benefits you gain over hearing with one ear, and those have to do with things like localizing sound, where sounds are coming from, hearing better in certain noisy situations where the fact that you have two ears allows the brain to sort of filter out the noise to some degree and improve the speech signal. And then there's something called summation, which is the fact that when you have more information coming in, the brain has more to work with. So what we see in patients with cochlear implants and single-sided hearing loss is that they can develop some of those binaural benefits of having two ears, specifically localizing where sounds are coming from and hearing better in noisy situations. As well, many patients derive subjective benefit based on questionnaires such as the speech and spatial qualities of hearing questionnaires and the hearing benefit questionnaires that we administer to these patients. So what we're seeing is patients with single-sided hearing loss and cochlear implants do quite well, but it's still in an experimental status in the United States, and it's not FDA approved. And then there was another question about bilateral asymmetrical hearing loss when the better ear doesn't qualify. And this is another area of research that's currently being performed. There have been a couple studies looking at this, and there's currently a study that's getting ready to be performed that's a multi-center study that will be looking at that. So these are active areas of research. And but I will say the patients that have cochlear implants for a single-sided deafness and a normal hearing in the other ear, they generally are extremely happy with them. They are gaining benefit, and this is something amazing to me, again, about the brain's ability to use this information, because as Jordan alluded to, the quality of the sound is not normal, but yet these patients who have normal hearing in one ear still wear their cochlear implant in their deaf ear all day long. So they must be gaining significant enough benefit from it for the brain to find it useful. So this is where the brain comes in and takes that information and incorporates it, and this is where the fact that the central nervous system, the brain, can use this degraded information but yet make it useful to the patient really is an amazing thing. And it shows us how little we understand really about how the brain interprets this information and puts it together. And these patients that are now undergoing implants for single-sided hearing loss are potentially a way for us to learn more about this kind of way that the brain puts those sounds together, puts normal hearing together along with implant information. So it's an active area of research, and we anticipate that this will continue to be a place that will learn a lot about the auditory system. It's a very fruitful area of research. Jordan, I wanted to go back to talking about something you said about the older patients. So you said, sometimes we have patients, we activate them and they immediately do well, and some do not. How do you counsel a patient about the length of time it will take them to get benefit from an implant? Like, what do you generally say to a patient saying, when am I going to start to gain benefit from my device? What's the average time that you would quote someone for something like that? How do you counsel them?
I have my stock phrases that I use. I always say, we see the biggest improvements in 6 months and then smaller improvements after that. It can be really difficult when a patient has been through those 6 months and they're not seeing improvements, and they want it so bad to sound closer to speech. They want to be able to understand people without reading their lips, but in not every case is that going to happen. Many people are still going to rely on lip reading and using captions when they watch TV, things like that, to help facilitate communication, to hear better. I never want to give people a number. I never want to say, 1 month from today you're going to be hearing better. And part of that is because it's an ongoing rehabilitation process. There really is no end. We really try to give people some cautious optimism going into the surgery, but still people want it to be a perfect fix so bad. They really want it to just click one day. It's very different from, say, an eye surgery where they remove a cataract or they do a lens correction. I know nothing about eyes, so I don't know how that works, but it's way different from that. It's almost like having braces that aren't going to come off. We're constantly fine-tuning and tweaking them to get them in the right position, to get your hearing in quote-unquote the right position. And initially that takes a lot of appointments. We here at House will do 2 appointments for the first, for the activation. We'll do a follow-up a couple weeks later. We'll do a visit at 6 weeks, and then several months later. And then later on, it's only every year. Some people, they need to come in quite a bit more than that because it's just something's wrong, it's not sounding good. I would say a vast majority of them do just fine on that schedule. Mm-hmm. But there are many people who need to keep coming back, and we have to keep working at it. And we want it so bad to work, but sometimes it takes a lot more effort to get there. And that's kind of why we give people that cautious optimism speech. We try to beat down your expectations before you get the surgery. Mm-hmm. Because there are those patients who get those YouTube worthy moments where they turn it on and everything's back to normal and it's perfect, but by far most people won't have that reaction. You might only hear some buzzing or static that first day we turn it on, and it may start out being more rhythmic, more just general sound awareness. Hopefully over time we'll start to improve that. Now when you have a better hearing ear, maybe with a hearing aid on the other side, or if you're one of those lucky few who had a single-sided deafness and got an implant, that hearing ear is going to help make make sense of the new sound. So it's almost like one ear's hearing black and white and the other's hearing in color. And if you give a little splash of color to the other side, then the brain is much better at picking up what it's hearing. If you have any kind of acoustic hearing on that other side at all, it's definitely going to help because it's more familiar. So yeah, I think
Great.
Yeah, I'm walking in circles now.
I almost think that we're catching up on 40 minutes here, and so we're probably going to close this pretty quick here. But I think we need to have a separate live session on potentially on alternative indications for cochlear implants, like newer indications, and talk a little bit more about patients with pretty good hearing in their other ear, when they might be candidates, newer testing for sentence understanding, how we assess a little bit more of that. So maybe we'll have a second session on that. But the last question I want to close with is, you have a patient come to you that's very hesitant, very apprehensive about the idea of this device and going forward with this. What do you say to reassure patients that are coming to you that are interested but potentially apprehensive? What do you say to them to calm them down, to counsel them about the fact that, is this worth it? I mean, when they ask you that, is this worth going through? The patients will ask you, is this worth it? What do you say?
So after we wrap up all of our testing to figure out if you're a candidate or not, there's a lot of time when we say right off the bat, yep, you're a candidate and this is definitely going to help. There are many times when we say, you're right on the border there. You could proceed with a cochlear implant and it might help you, or you could stick with hearing aids because you're doing fairly well with them. Yeah, in many of those cases it can be challenging, especially if a person isn't really willing to go through with it. If you don't want to risk losing what you have, then it's tough for us to force you to do that. If you don't have any hearing at all, then it's kind of an easy decision. The surgery, it lasts 2-3 hours tops, and then there's a week or so of healing, and then you're pretty much back on your feet. But for those people that are a little bit too afraid to lose what they have, it's definitely understandable. The FDA criteria that we use to determine if someone is a candidate, they're set at a certain point that allows us as audiologists to make the decision whether or not a cochlear implant might significantly improve your hearing abilities. And we want to be sure that it's a significant improvement. Because if we're only going to bump your speech understanding, 5-10%, then it's not really worth losing what you have and going through the surgery and the follow-up and dealing with that to just gain a little bit. But if you're at the bottom of the barrel, if you've got nothing at all and you need to get back into the hearing world, then that's when it's an easy decision. That's when we can say, oh, this is definitely going to help. Keep in mind that does involve factors including the type of hearing loss, the duration of hearing loss that we talked about, whether it's one ear or both, your hearing aid history. There's plenty of factors, and I could go on, but I think we're a little short on time.
Well, appreciate Jordan coming by, and we'll have you back,
absolutely.
And we'll get you back and talk about maybe a little bit more about some of the newer indications and borderline cases, and when we might do something a little bit different than we did in the past. But appreciate you coming over, and it was great. I think everybody had a good experience with this, and we're glad you came. So thank you very much, and we'll close the transmission for tonight. Thanks, everybody.
Thanks.